and is a joint collaboration by the British Society of Gastroenterology, that is BSG, and the European Society of Gastroenterology and Endoscopy. So they have collaborated these updates in June 2021. So basically, this is a recommendation for the management of patient or antiplatelet therapy plus or anticoagulation undergoing elective endoscopic procedure and their risk stratification. So they have recommended that all patients should be individualized and they are advised for the thrombotic risk of discontinuing antiplatelet or anticoagulation as well as the hemorrhagic risk of continuing therapy. For all endoscopic procedure, we are recommended continuing aspirin with the exception of ampulectomy during ERCP. And if you are considering aspirin discontinuation, this should be an individual patient basis depending on the risk of thrombosis versus hemorrhage. These are some of the general points. So basically, they have divided the antiplatelet and anticoagulation depending on the whether it is a low risk or high risk, and in high risk whether it is associated with a low thrombotic risk or a high thrombotic risk. So we are going to see each one of the each topic one by one. So low risk endoscopic procedure.
Dr. Suresh, could you
Yes,
just
sir.
which are the common guidelines which are present available, which are societies which has produced the various guidelines before starting the before talking about the present guidelines?
Sir, first one is the British Society of Gastroenterology, and another is the European guidelines for gastroenterology endoscopy, sir.
Okay, actually, the Asian Pacific Society and even the American College of Gastroenterology has put up the guidelines, but I think this is the most recent guidelines which has been published regarding the endoscopic practice.
Even ASG had a guideline, I think, but as you rightly said, this is possibly the latest and worth looking at. Okay.
So low risk endoscopy procedures are for low risk endoscopy procedure, they are recommending to continue P2Y12 receptor antagonist, that is clopidogrel, ticagrelor, or prasugrel as a single or dual antiplatelet therapy. When it is added with the aspirin, it is called as a dual antiplatelet therapy. So they are for low risk patient, they told to continue both as a single or dual antiplatelet therapy. For warfarin, the therapy should be continued. It should be ensured that the INR should not exceed the therapeutic range. It may be 1.5 to 2.5 in the week prior to the procedure.
I think it would have been worth first if you give us the risk of what is low risk endoscopy procedure and what is high risk endoscopy procedure before you talk about how to approach them.
For antiplatelet, the low risk procedure are diagnostic procedure, that is associated maybe plus or minus biopsies. Then biliary and pancreatic stenting without sphincterectomy, diagnostic US endoscopic ultrasound, device assisted enteroscopy without polypectomy. These are the low risk procedure. And high risk procedure, uh, these are polypectomy, ERCP with sphincterotomy, ampulectomy, EMR, ESD, dilatation of the strictures. Special mention here, Crohn's and Achilles cardia strictures. They are having high risk of bleeding, sir. And therapy for the varices, peg insertion, endoscopic ultrasound with FNA, esophageal or enteral or colonic stenting. These are the high risk. In that also high risk, the low risk condition associated are ischemic heart disease without coronary stent, cerebrovascular disease, peripheral vascular disease. So in this, even if patient is having ischemic heart disease and the drug-eluting stent has been put for more than 1 year, that can be come under low risk. And for a bare metal coronary stent more than 1 month, that may be come into low risk condition. And high risk condition if uh, drug-eluting coronary stent is less than 12 months and bare metal coronary stent less than 1 month. For warfarin, basically same as like that for antiplatelet, only that the esophageal enteral and colonic stenting are low risk factor here, and here the esophageal and gastric radiographic ablation, they are high risk for this patient. And for warfarin, for warfarin, they are again classified as a low risk and high risk, whereas for a directly acting oral anticoagulant, there is no such differences, sir. All are high risk are considered as a high risk only. There is no sub-classification for them. So warfarin, low risk condition are xenograft heart valve, atrial fibrillation without high risk. There is CHA2DS score less than 4 or venous thromboembolism of more than 3 months. For high risk, prostatic metal heart valve in mitral or aortic position, prostatic heart valve and atrial fibrillation, mitral stenosis with atrial fibrillation with previous stroke or TIA, and 3 or more of the following, that is congestive heart failure, hypertension, basically BP, blood pressure more than 140/90, age more than 75 years of age, diabetes mellitus, then atrial fibrillation and stroke and TIA within 3 months after venous thromboembolism. So these are the risk condition for antiplatelet warfarin. So we will go ahead with the one by one. So for low risk, antiplatelet should be continued, whether it is a single or dual. For warfarin, we should continue the warfarin, and INR should be checked 1 week prior to the procedure, and it should be within the therapeutic range. And for directly acting oral and anticoagulant, omit the morning dose of that procedure day only for low risk procedure. Whereas for high risk procedure with a low thrombotic risk, they recommended to discontinue P2Y212 receptor antagonist 7 days. That is 1 week before the procedure. And in patient with dual antiplatelet, we recommended continuing aspirin. For a high risk patient with a low thrombotic risk for warfarin, they recommended to stop warfarin for 5 days, and no need of heparin overlap in this case for low thrombotic risk, and check INR prior to the procedure to ensure if it is less than 1.5. If INR is more than 1.5 but less than 5, we can reduce the dose to the half, but it is not mentioned half, but generally they are doing the dose, they will reduce the dose to the half, and they will again monitor for 1 week. If it is more than 5, then abandon the procedure.
Dr. Suresh,
Yes,
could you just tell me what is the rationale of stopping the P2Y12 receptor antagonist for 7 days? What is the rationale behind this?
So basically, for the it is an irreversible inhibitor, sir. It will act for 7 days. That is the rationale, sir.
No, so because the platelet life is around 7 to 10 days, so once it irreversibly inhibits it, so we have to wait for at least 7 days.
Yes, sir.
So you mentioned about the newer antiplatelets. So is there any difference in the action of the newer antiplatelets when compared to clopidogrel? You mentioned about ticagrelor and prasugrel. Is there any difference?
So they are irreversible inhibitors, sir.
The ticagrelor is a reversible inhibitor. So the studies say that you can stop it. You can stop it for at least 3 to 5 days is enough. You don't have to wait for 7 days if you are using ticagrelor when compared to clopidogrel or prasugrelor, because that inhibits reversibly, while the other two drugs are irreversible inhibitor of platelet action.
Yes, sir. Thank you, sir. For high risk endoscopic procedure with the high thrombotic risk, the warfarin should be temporarily discontinued and substituted with the low molecular weight heparin, and it should be started. Lmwh should be started 3 days prior to the procedure, and INR we have to monitor, sir. And Lmwh should be stopped 24 hours, not 12 hours. 24 hours prior to the procedure for high risk, high thrombotic risk.
Are you sure we have to monitor INR? Usually for low molecular weight heparins, we don't monitor INR.
Yeah, I was also going to ask the same question, that in LMWH, once you start, there is nothing to monitor. And the second question which I have is that when should the person receive the last dose of LMWH before you do the endoscopy?
24 hours before the procedure.
So for last 24 hours, there is nothing. The patient is on.
Nothing. Yes, sir. According to these guidelines, 24 hours prior to the procedure.
Okay. And your question of monitoring, which has been asked by Dr. Thomas, is it written somewhere that you do the monitoring while the patient is on LMWH?
No, sir. Only to recheck while stopping the INR. That much only, sir. Not written to monitor INR, sir.
Okay.
Unless you are using an unfractured heparin, I don't think it's required to monitor INR. If you are using unfractured heparin, you may have to monitor APTT or something like that.
For high risk, yes, sir. For high risk endoscopic procedure,
So can you tell me which patients will you put on regular heparin and not LMWH?
Sir, in whom the creatinine is high, basically CKD patients, sir.
Okay.
So high risk endoscopic procedure in patient on directly acting oral anticoagulant. The last dose should be for high risk procedure. Last dose should be taken 3 days prior to the procedure. And with the pay for specifically for diabetic retinopathy with the creatinine clearance of 30 to 50 ml per minute. So last dose should be taken 5 days prior to the procedure. So these are the same thing which is in a flow chart, sir. Clopidogrel procedure for low risk procedure, they told to continue the therapy. For high risk, if it is a low risk condition, sorry sir, in this it is a 5 days, it should be 7 days before the endoscopy. The stop clopidogrel procedure or ticagrelor 7 days prior to the endoscopy and continue aspirin if already prescribed. And where there is a high risk condition, we have to discuss this with the cardiologist and considering stopping the clopidogrel if drug-eluting coronary stent is more than 1 year and bare metal coronary stent more than 1 month and continue aspirin.
So
And
tell me one thing. I have a question to you. If
yes,
somebody is on say clopidogrel
yes,
and not on ecosprin, now will you switch to ecosprin to reduce the risk of
yes,
thrombotic complications, or you will be just discontinue clopidogrel?
Sir, if it is a high risk condition, we have to continue with the. We have to discuss with cardiologist, and we may have to continue clopidogrel. Whereas in acute GI hemorrhage, if patient is on low risk condition, we may shift the patient from clopidogrel to aspirin, as aspirin has less chances of bleeding.
Okay.
The same for warfarin. Warfarin for low risk patient, check INR 1 week prior to the procedure. And if INR is therapeutic range, continue usual daily dose. Don't stop. And if INR above therapeutic range, that is but less than 5, reduce the daily dose until INR returns to therapeutic range. And for directly acting, omit the morning dose. And for high risk, with a low risk condition, stop warfarin for 5 days and check INR prior to the procedure to ensure INR less than 1.5. Restart warfarin on the same day, evening, as the usual dose and check INR 1 week later to ensure adequate anticoagulation. For high risk, stop warfarin for 5 days and start LMWH 2 days after stopping the warfarin. That is 3 days before the procedure. Omit LMW on the day of procedure for 24 hours and restart warfarin evening of the procedure and usual daily dose. Continue LMWH until INR is adequate. And for directly acting oral anticoagulant, 3 days we have to stop the drug. And if GFR is between 30 to 50 or less than that, we have to stop that drug for 5 days.
So can you go back to the previous slide?
Yes, sir.
So in the first group, low risk procedure, you are stopping DOAC in the morning of the procedure. So can you give the DOAC on the next day, or you again start the DOAC 2 to 3 days after the procedure?
No, sir. Same day we can start, sir. I mean, next day we have to start.
Next day. All right. Okay.
Same thing in the tabulated form, sir. Here the endoscopic polypectomy is a high risk procedure. But if it is a polyp size, if it is less than 1 centimeter, we can consider cold snare resection of polyp who on continuing clopidogrel monotherapy for polyp less than 1 centimeter.
Is there any difference for small polyps was cold versus hot snare?
Yes, sir.
Are you
Cold
coming?
snare. Okay, I can hear. My am I audible, sir?
Yes, you are audible.
Yeah.
You
Yeah,
did
sir.
mention that cold snare is fine. You are not comfortable with hot snare.
Yes, sir. Hot snare and one hot snare and pure cutting technique both are associated with the higher risk of bleeding, sir. So compared to cold snare and blended current, so polyps of less than 5 centimeter, less than 1 centimeter, they have a lesser chances of bleeding according to these guidelines, sir.
See, I totally agree with your cold snare, with the hot snare and the size, but I don't know whether the present guidelines still talk about coagulation current and the blended current and the cutting current. Does it mention in the present guideline that the
Yes, sir,
type
it
of
is
current
mentioned.
matters?
Yes,
It
sir,
is
it is
in
mentioned.
this guideline it is mentioned?
Mention, sir. It will come, sir.
Okay, all right.
I just want to add one. The study was based on a Japanese study where they did a RCT for the small polyps, and they found that it was mainly the delayed bleeding which was less when compared to the early bleed. So it was found that the delayed bleeding was much less when they did the cold snare for less than 1 centimeter polyps.
Correct, sir. So basically, one by one, sir, a post-elective endoscopic procedure, if antiplatelet or anticoagulation therapy does discontinue, then they recommended to resume this antiplatelet or anticoagulation through 2 to 3 days after the procedure, depending on the perceived hemorrhage and thrombotic risk. And for all patients on antiplatelet or anticoagulation, they recommended advising that there is an increased risk of post-procedural hemorrhage compared with the patient not on this drug. We have to tell this to the patient. And one by one, sir, we we usually see in our day-to-day practice, sir. So acute GI hemorrhage. So for aspirin, if it is given for primary prophylaxis, it should be permanently discontinued. If it is for secondary prevention, and for if aspirin is using for secondary prevention and should not be routinely stopped. If it is stopped, and it should be recommenced as restarted as soon as hemostasis is achieved, or there is a no further evidence of hemorrhage. The patient is
Dr. Suresh, what
yes,
will
sir.
happen if you stop aspirin? What are the figures like? What are the adverse effects that can occur if you stop aspirin? Patient on regular aspirin, you're stopping. So what is the figures of the events that may occur?
So there are very famous studies. Can you quote some of them? Hong Kong group has presented a lot of data on this, that if you stop ecosprin, then the chances of cardiovascular deaths are higher than with continuing. So most of the people now would start aspirin fast. Maybe the 2 days to 3 days may be the time. Is that what you wanted to hear, Dr.
Yeah,
Thomas?
it has been shown that there's around threefold increased risk. So a patient who is on aspirin, you're stopping it. So the chance of developing a cerebrovascular event or the cardiovascular event is threefold. And 70% of these events occurs within 7 to 10 days of stopping. So more events will occur more recently. So it's more important that you restart as early as possible, because the majority of the events will occur as early as 1 week.
Okay. Thank you. For dual antiplatelet, if it is continue possible, if it's continue if possible in patient coronary stent in situ, and management should be discussed with the consultant intervention radiologist. In case of major hemorrhage, they recommended to continue aspirin if the P2 Y12 receptor antagonist is interrupted. And if still it is indicated, then restart within 5 days of stopping antiplatelets. And for anticoagulation, they recommended to withhold oral anticoagulation and correcting coagulopathy according to the severity of the hemorrhage and the patient thrombotic risk in coordination with the consultant radiologist or hematologist. The correction of the coagulopathy should not delay the endoscopy or radiological intervention. So in patient with the yeah, in patient with the warfarin, sir, who are taking vitamin K antagonist, who are hemodynamically unstable, they recommended to give vitamin K dose with the 4-factor of PCC, that is prothrombin complex concentrate, or FFP, if it is not available. In patient with the who are taking directly acting oral anticoagulant, so who are hemodynamically unstable, for dabigatran, idarucizumab is an antidote, and for anti-10A factor inhibitor, andexanate is available, sir. If it is not available, then give 4-factor of prothrombin complex concentrate.
Are these available in India? Are these available in India?
No, sir. Andexanate is not available, sir. Idarucizumab, I don't know, sir.
But 4-factor is available.
Or it is also difficult, sir.
What's the
Now the problem with fresh frozen plasma is that the amount required is actually very large.
Yes, sir.
If you really want to correct the abnormality. What about oral vitamin K versus intravenous vitamin K? Have you looked at Dr. Thomas talked about Asia Pacific guideline? Have you looked at Asia Pacific guideline, which talks about giving a very low dose vitamin K rather than high dose, because high dose may be counterproductive sometimes. All right, carry on.
I just want to ask, when you compare warfarin with the newer anticoagulants, is there any literature that's saying that the bleeding is less or bleeding is more when we compare with the newer direct acting oral anticoagulants?
Sir, for directly acting oral anticoagulants, sir, bleeding, there are no much studies actually, but bleeding risk is high, and we don't have any monitoring parameters also, and antidote also it is difficult to get, sir. So I would say, sir,
There are basically the newer DOACs, they say it's lesser of GI bleeds when compared to the warfarin. And there are very few studies. They're showing that the apixaban has the lowest risk for bleed when compared to dabigatran. And rivaroxaban has the highest chance for GI bleeds when they compare all the 3 newer DOACs. So these are all small studies.
Yeah, but you would also agree, Dr. Thomas, as he rightly said, that monitoring is more difficult with these rather than with the conventional medicines, warfarin.
One more thing, DOACs are very rapid onset. Like
yes,
within
sir,
2 hours, they will reach their maximum potential, and it will wean off within 24 hours. So even though if you don't get the antidote after 24 hours, its action is over.
yes, sir.
Carry on.
Yes, sir. For anticoagulation, if patient is on low thrombotic risk, it is suggested to restart anticoagulation as soon as possible after 7 days of anticoagulant interruption. And where is in high thrombotic risk, earlier resumption of anticoagulation with heparin bridging, preferably within 3 days, is recommended. The same thing for warfarin heparin, sir. INR should not exceed the therapeutic range in 1 week prior to the procedure. To check INR the first week, 1 week before the endoscopy. If INR in the therapeutic range, continue with the usual dose. If INR is above the therapeutic range but less than 5, then reduce the daily warfarin dose until INR returns to the therapeutic range. If INR more than 5, then defer the endoscopy and contact the anticoagulation clinic or medical practitioner for advice. For a high risk procedure, in patient with a low thrombotic risk, we recommend to discontinue warfarin before the procedure and check INR prior to the procedure to ensure it is less than 1.5. And stop warfarin for 5 days before the endoscopy. Check INR prior to the procedure to ensure the value of less than 1.5. On the day of the procedure, restart warfarin with a daily dose that of same night, sir, and check INR after 1 week. In patient with the high risk, high thrombotic risk, sir, I recommend the warfarin should be temporarily discontinued and substitute the Lmwh. Warfarin should be stopped for 5 days and administer the last dose of Lmwh at least 24 hours prior to the procedure. Check INR prior to the procedure to ensure value less than 1.5. Warfarin can be resumed on the day of the procedure with the usual dose of that same day, and restart the daily therapeutic dose of Lmwh on the day after the procedure and continue Lmwh until satisfactory INR is achieved. So basically, sir, as you rightly said, sir, Ronnie sir, Hemorrhage in endoscopic procedure, hemorrhage are basically two types. One is the immediate and again the delayed, that is up to 2 weeks. So minor hemorrhage is common when it is called as significant when HB falls for more than 2 grams or necessitated blood transfusion or causes an unplanned hospital admission. So we'll see one by one. For diagnostic endoscopy and mucosal biopsy, there is no increased risk of hemorrhage from biopsy has been found in the studies of patients on aspirin, clopidogrel or warfarin. For resection of GI polyps, polypectomy including polypectomy have a high risk of post polypectomy bleeding, that is 0.07% to 1.7%. The risk factor for post polypectomy bleeding are polyp size, use of pure cutting current and use of non microprocessor control current for endoscopic mucosal resection. The use of endoscopic clip or submucosal injection of diluted epinephrine may also reduce the risk of post polypectomy bleeding. It may be safe to undertake polypectomy for polyp less than 1 centimeter size on clopidogrel monotherapy. To minimize the risk, a cold snap polypectomy may be advisable. Alternatively, temporarily substituting aspirin for clopidogrel may be desirable 7 days prior to the colonoscopy. This we have discussed earlier. For ESD, endoscopic submucosal dissections, continuing clopidogrel or prasugrel aspirin use did not increase the delayed hemorrhage. The few data available on esophageal or duodenal ESD on antithrombotic. The risk of bleeding after esophageal ESD is lower as compared to the other location. For high risk endoscopy procedure under oral anticoagulation, upper and lower GI ESD were found to have significantly associated with post procedure hemorrhage. So basically, to reduce this hemorrhage, we can give PPI. We can apply clips or hand suture, local fibrin glue, polyglycol acid sheet, or hemostatic powder. We can apply. Who patient who are antithrombotic or anticoagulation. So ERCP, hemorrhage rate of following ERCP was 1.3%, and majority of the 71% of this was graded as a moderate and 29% as a severe. The mortality rate was 0.05% overall. So basically, post ERCP hemorrhage, the ESG guideline says that the risk factor for post ERCP hemorrhage are anticoagulant intake, platelet count less than 50,000, cirrhosis, dialysis for end-stage renal disease, intraprocedural bleeding, and low endoscopic experience. Endoscopic experience. To reduce the risk of hemorrhage, avoidance of sphincterotomy prior to the biliary stenting, and use of blended current rather than the pure cutting current. For ampulotomy, the hemorrhage occurs in 10.6% of ampulotomy with approximate 25% requiring blood transfusion and 5% requiring intervention. So routinely closing the mucosal defect with the clip following ampulotomy is effective to prevent the delayed bleeding. There are no data on ampulotomy and anticoagulant or P2Y2 Y12 receptor antagonist, as these are usually withdrawn. Given the high hemorrhagic rate, withdrawal of aspirin should be considered on an individual basis depending on the risk of thrombosis. So, yeah, endoscopic ultrasound, FNA. It is an invasive procedure. It is considered as a high risk, sir. Your cystogastrostomy or necrostomy have a significant risk of major hemorrhage. Should be considered as a high risk for P2Y12 receptor antagonist or anticoagulant. The risk of aspirin is unknown for FNA, sir. For endoscopic dilatation, dilatation of GI structure in the upper and lower GI tract appears to be low risk, except for Crohn's disease related stricture and balloon dilatation of achalasia. There are no data on dilatation of stricture on antiplatelet or anticoagulation, but together with the inaccessibility at the site of the hemorrhage for endoscopic hemostasis has led us that consider the endoscopic dilatation as a high risk procedure on P2Y12 receptor antagonist or anticoagulant. Endoscopic stenting, sir. These are
you would need to wind up in another 2 minutes so that we have enough time for the next discussion.
Endoscopic stenting in the on-site GI tract at a low risk for hemorrhage within the 7 days. Patient on antithrombotic may be increased risk of delayed hemorrhage. For PEG insertions, risk of it is a high risk procedure. Risk of bleeding secondary to the PEG tract bleeding, injury to the gastric artery, splenic or mesenteric vein. On rectal sheath hematoma, patient can present a massive retroperitoneal bleeding. Device assisted enteroscopy, the risk of bleeding may be low for diagnostic procedure, but therapeutic procedure such as a polypectomy that can be classified as a high risk of hemorrhage on antithrombotic. For esophageal varicose banding, sir, a study of plant DVL in cirrhotic patient, patient who on LMWH showed no increase in post-procedural hemorrhage or reduction in the survival compared with those on not on LMWH. And placing no more than 6 band per session may help to reduce the risk of post-banding ulcer hemorrhage. This is an important point, sir. The ablative therapy, esophageal and gastric radiofrequency ablation is a high risk patient, sir. But there are no data on aspirin. But they advise to continue aspirin as of now, sir. And there are no data on continuing antithrombotic with respect to the low risk of hemorrhage from APC, and therefore they are unable to provide specific guidelines in this regard. Thank you.
So there's some question in the chat box from Dr. Vikram Patil. Can anybody see that question? Yeah, what is the new as compared to the previous guideline?
So previously it was they told to stop antiplatelet for 5 days. Now it is 7 days, sir.
So is that the only difference between the previous guideline of 2016 and now?
No, sir.
I think previous guideline did not talk much about DOACs so much. We have this DOAC and the various types of DOACs being added this time. And I think basically the concept is the same, that you have to balance the risk of bleeding to risk of thrombotic events. And then you find out the risk of bleeding is higher or risk of thrombotic events is high. One question I think we have overcrossed our time is there any preference for the modality of treatment for bleed in a patient who is on antiplatelet drugs presently or was on antiplatelet drug till recently? When I'm talking about this mechanical methods like clipping compared to thermal methods like use of a gold probe or an argon plasma coagulation, is there any guideline which is given? In my practice, I often prefer a mechanical method over a thermal method while I'm managing somebody who is been on antiplatelet or anticoagulation.
The guidelines
You did mention in the guideline that RFA is associated with high risk.
High risk,
so when you talk of RFA, you can extrapolate that and talk about thermal procedures being more risk of bleeding in patients with antiplatelets. There's no guideline recommendation.
So they are telling clipping is better than thermal.
So I think that this is theoretically correct, possibly, that even for a duodenal ulcer bleed, if there's a significant bleeding and you are going for a method, I think either a combination of epinephrine with a mechanical method or only mechanical method may be preferred over using gold probe or argon plasma coagulation or a heater probe. Now there was one last question, is that why there's a difference in the approach to stenting as compared to when you talked about low risk and high risk for endoscopy. There was stenting moved from high risk to low risk.
Yes, sir. Basically in DOAC, sir, there are no studies, sir. There are no studies, sir. That's why.
All right. So should we move on to the second presentation?
Yes, sir.
Dr. Thomas?
Yeah. So I think we have had a good discussion. The second presentation will be presented by Dr. Karthik on ATT-induced liver injury.
Dr. Karthik, you are the second year or a final year student?
I'm a final year, sir.
Okay, so you are appearing for your theory exam in June.
Yes, sir.
All right.
Good evening, all. Today, my topic is a very routine topic which we will encounter in the routine of our practice, the ATT-induced liver injury. As we know, the tuberculosis is one of the deadliest communicable disease, and also in India there is a much more burden of tuberculosis even still. So as per the WHO guidelines in the 2020, almost all over the world by 9 million people developed TB with mortality of 1.5 million. Among that, MDR TB is 3.5% of the newly detected and 20.5% of previously treated cases. And also XDR is around 9% of MDR TB. And anyway, it is MDR TB is also rampant. Among 1.1 million were found to be an HIV seropositive. So, our topic is the liver. As of we know that liver is a metabolic factory for all these drugs, especially all the most of the first line antitubercular drugs will be metabolized by the liver. So we should more concern about these drugs. And this drug-induced liver injury also is a very commonly we will see, but it is often unrecognized because of the liver damage in treatment of tuberculosis in most of the settings. So as we know, the first line drugs, isoniazid, rifampicin, and pyrazinamide. These are the essential components to treat the tuberculosis. So all these three are the hepatotoxic. So and the several second line drugs, including the ethionamide, prothionamide, and a few fluoroquinolones and the paraaminosalicylic. These are also potentially hepatotoxic. So we should follow some guidelines whenever we are giving an ATT. So if any combination of if ART, if patient has an HIV along with the tuberculosis, then all these ART patients also ART drugs also hepatotoxic, like ritonavir, adenosine, and nevirapine. So we had to modify the drug regimens whenever we are combining all these drugs. So the risk of DV will be more in these patients. So this even the treatment of latent TB infection also contributes to the pool of anti-TB delay. So mechanism, there are the four mechanisms by which these drugs will cause the toxicity. One is the direct toxicity, idiosyncratic, and induction of hepatic enzymes and allergic reactions. Among these, the direct toxicity is the dose dependent, and the remaining all these three mechanisms is the dose independent. So whenever you start the medication, immediately the patient will have the drug induced. This dose dependent is only because of the direct toxicity. So we should adjust the doses also if it is a direct toxicity. So this is a direct toxicity. It could be acute or subacute, increases with escalation of dose. And it is a free radical mediated necrosis usually, and no extrahepatic manifestations like a rash, fever, such a kind of things won't be there in the direct toxicity. Most of the times we will see as a patient will present as a transaminated when we were checking routinely LFT. Coming to the idiosyncratic toxicity, it is a most common types of DILI compared to the direct and other types. So it includes the both metabolic and hypersensitivity reactions, and it's largely independent of the dose. Whatever the dose you will give, the patient will present with the DILI. So, and it may occur any time post exposure. It can be an early or it can be delay up to weeks or months, like 3 months also it can happen, but less likely. Most of the times it will happen in the weeks after the starting the therapy. And the result for genetic and acquired variations also contribute to some factors in the idiosyncratic. Some genetics like HLA genetics also will contribute to this idiosyncratic. And another mechanism is the induction of hepatic enzyme. Is because of the alteration of the plasma drug levels by induction of enzymes by some other drug, because of the interaction between the other drugs also it can cause hepatotoxicity. Uh, and coming to the allergic reactions, it is also mostly immediate cause of immediate way of drug toxicity. And most of the times, allergic reactions will manifest with the fever, lymphadenopathy, rash, and severe hepatocytic. Other mechanisms mostly we'll see as a transaminitis rather than the symptoms and manifestations. So the mechanisms usually there's 6 mechanisms. The one is the disruption of intracellular calcium homeostasis, and then the cholestatic damage, which will cause the damage of the bile canalicular secretion, so which will lead to the cholestatic type of bilirubinemia, and the interruption of transport pumps and loss of Willis process, and reactions involving cytochrome P450, and the apoptotic programmed cell death and inhibition of the mitochondrial function. And coming to the toxicity of the individual drugs, coming to the isoniazid, usually it is not the mechanism of hepatotoxicity is not well understood, the isoniazid, but most of the times it is a very delayed onset. So it will take weeks to months, and the 60% incidence is in the first 3 months, and no hepatotoxicity on rechallenge. So usually it won't cause hepatotoxicity and the rechallenging. And it is associated with the reactive metabolite and the immunoallergic. This HLA DQB1 will be more prone for this, and also causes the mitochondrial injury. So it is mediated through the metabolites such as an acetyl isoniazide and the monoacetyl hydrazine. Initially, they thought that acetyl isoniazide is the most potential hepatotoxic metabolite, but later it is established as a monoacetyl hydrazine is the most hepatotoxic product. Coming to the histopathology, it resembles the viral hepatitis, showing a hepatocyte necrosis, ballooning degeneration, and the inflammatory infiltrates. The absence of symptoms, usually hypersensitivity symptoms will be absent in this patient, like rash, fever, arthralgia. Usually we'll see as only transaminase instead of the symptoms. So that is also the reason why we are not predicting immediately this hepatotoxicity. Most of the patients are undiagnosed. And coming to the rifampicin,
Dr. Karthik, could you just tell
yes,
something about the acetylator, fast acetylators and slow acetylators? And
yes, sir. This is the acetylators also. This is the metabolic products usually. Some studies are showing that initially the fast acetylators are the more hepatotoxic than the slow acetylators. But it is a debatable study, sir, now. But it's
I think the literature showing the slow accelerators are more literature showing towards slow accelerators causing have more of toxicity when compared to fast accelerators.
Yes, sir. And rifampicin it occurs usually earlier toxicities, and it produces a patchy cellular abnormality with marked periportal inflammation. So mechanisms include the conjugated hyperbilirubinemia, because it will decrease the canalicular bile secretion. So, and also it will inhibit the major bile salt exporter pump also it will inhibit. And there will be a dose dependent competition with bilirubin for clearance at sinusoidal membrane. So usually patients will present with the elevated bilirubins rather than the transaminitis along with the elevated bilirubin also. And the hypersensitivity reactions, these are very rare, more common with the large and intermittent doses. Like initially the WHO guidelines or Indian DART guidelines showed intermittent doses of rifampicin. So in such a patients, the hypersensitivity reactions are more. But now we are using almost like a regular routine doses. So the symptoms will be like a flu-like symptoms, rashes, lymphadenopathy, and cold, common cold. Coming to the pyrazinamide, it is the most hepatotoxic drug among all the first-line drugs. So this half-life is 10 hours, and it can increase to 15 hours in pre-existing liver disease like a CLD or any chronic viral hepatitis conditions. So it exhibits a both dose-dependent and idiosyncratic. So that's why now newer studies are showing the lesser dose, less than 35 milligram per kg body weight, are showing less hepatotoxic. So some RCTs are telling that we can continue the pyrazinamide in the low doses also. So and there may be shared mechanisms of injury for both INH and pyrazinamide. Some similarity because of the in molecular structure. So patients with the previous hepatotoxic reactions with INH, they are more prone for more severe reactions with the rifampicin and pyrazinamide combination. And they may include the hypersensitivity reactions with eosinophilia and liver injury or a granulomatous hepatitis kind of thing. So many factors will be implicated in this anti-TB daily, like ethnic and racial variation. So in India, more common. There's 11.5% risk will be more compared to the Western, like it's only 4.5%. And the age more than 50 years and less than 35 are more prone. And gender, females are more prone for daily. And also genetic, as HLA-DQ1 is absence of HLA-DQA1 will more prone, and the presence of DQB1, and they're the independent risk factors for DD. And alcoholism and underlying CLD of any etiology like chronic hepatitis B, hepatitis C, or HIV. And the poor nutrition status also will exaggerate this, and the decreased serum albumin. And the types of tuberculosis. This is also somewhat debatable topics, like extensive, but some studies are showing that extensive cavitary form of pulmonary TBs and the TB meningitis are more prone for the DILI. And the accelerator phenotype as a slow versus fast accelerator. Previous suggestion was the rapid accelerators were more prone, but after the newer studies and all, the slow, as you said, sir, slow accelerators are more toxic. The clinical presentation, most of the times patient won't present with the symptoms, so they will present with the transamenitis like an investigations modality. But some patients with present with acute viral hepatitis like presentation, like a vague abdominal pain, nausea, vomiting, and some may present with the hepatic failure, fulminant hepatic failure with the bleeding manifestations with coagulopathy. And cholestatic hepatitis will be most common, like obstructive jaundice kind of picture because of the cholestasis. And the hypersensitivity signs may come into the picture, and also cirrhosis and primary hepatic neoplasms also. By the imaging modalities, we can find all this. The clinical syndromes is the hepatic adaptation. Hepatic adaptation is actually non-injury. It's a non-progressive liver injury. It is a transient elevation of liver enzymes, but it will subside by own without stopping the medication. Also, these transaminities will become a normal. So it is a physiological adaptive response actually. So more common with the rifampicin. In this, we can continue the rifampicin even with the mild elevation like 1 to 2 times of ALT elevation without any symptoms. So acute hepatitis or hepatocellular injury, so usually asymptomatic or some prodrome like fever, constitutional symptoms like nausea, vomiting may present, and markedly elevated, like yes, so more than 5 times elevation of ALT will be there. The jaundice and the coagulopathy in most of the patient, some of the patients, like an acute liver failure. And some patients will present like a granulomatous hepatitis, like hypersensitivity reactions, most common in the pyrazonamide toxicity. Like they will present with a fever, lethargy, rash, and the lymphadenopathy, vasculitis. It's like a hypersensitivity reaction kind of picture. So whenever we start the treatment, who are like increased susceptibility patients, there will be an initiation of liver injury. Some patients will be the adaptation. So it will resolve by its own without stopping the medication also, with continuing medication. If patients present with the clinical manifestations or increase in bilirubin, then it may lead to the severe injury, or sometimes it may cure, regeneration or repair will happen simultaneously. And come to the diagnosis, so we should differentiate between the two, that is the adaptation versus the true daily. In the case of adaptation, even though the transaminitis is there, patient will recover by his own without stopping medication. So patient won't have any clinical manifestation symptoms, and the ALT levels will be less than 3 times or 5 times of the upper limit normal usually. So in this patient, we can continue the treatment. So in the DILI, where more than the five times upper limit of normal or 3 times of upper limit of normal of ALT and with symptoms. So definitely we should consider DILI in this patient. So this is the Hy's law. usually this Heisler will tell the definition. The ALT level more than the 3 times of upper normal limit and total bilirubin more than 2 times the upper normal limit after excluding all other potential causes. So this is the definition as per the Heisler, Delhi definition. Well, but different. There are no specific consensus, but different guidelines are there, like American Thoracic and British Thoracic, CDC, Infectious Disease Control, and WHO guidelines. So many guidelines are there, and this TB cases. And in this ALT level more than 5 times of uh, upper normal limit, or more than 3 times with presence of the symptoms like nausea, vomiting, like prodromal. So we will consider as a DILI. And we'll come to the later all the comparison of all the guidelines. So for the score, usually we will come up with a RUCAM score for the diagnosis of ATT-induced liver injury, and the clinical. This depends on the clinical, biochemical, serological, and radiological features. Combinedly, we will validate the score and give the score as a total range is the -9 to the +14. High probability is more than 8. Probable is 6 to 8, and possible 3 to 5, and so unlikely 1 to 2. Less than 0 is we can exclude the delay. And also another is the R ratio. So its R ratio is mainly useful for the differentiating both the hepatocellular mixed or cholestatic jaundice. There's nothing but how much times of how many folds of ALT elevation by and the how many folds of ALP elevation. That is called the R ratio. More than 5 is a hepatocellular, 2 to 5 is a mix, and less than 2 is a cholestatic. Coming to the management, so baseline, so all the patients should undergo the baseline bilirubin and LFT before starting the liver function. So, and all the patients we should monitor, but patients of chronic liver disease, chronic use of alcohol, HIV, patients on heart, and pregnancy patients, and all the patients who are the chronic medical conditions of chronically ill patients, and concomitant treatment with other medication. These patients should have a very frequent LFT monitoring compared to the normal patient. These patients will require almost every week LFT in the first initial 2 months, later as per the requirement. The frequency is measured every 2 to 4 weeks for the first 2 to 3 months. This is in the normal patients, whereas patients with the chronic liver disease or any chronic viral hepatitis, they should be tested every week in the first 2 to 3 months. So if patient is having a ALT/ST less than 2 times of the upper limit normal, we can repeat after 2-week LFT, and we can continue the treatment, and we can repeat the LFT after 2 weeks. If levels are decreasing, then we can continue. If levels are increasing, then if it is less than 3 times with the symptoms, then we should stop the treatment. If it is more than 5 times of upper limit normal, regardless of symptoms, we should stop the medication and consider further next reintroduction of medication after once the transaminases become normalized. So, is the management options like question number 1, when to stop anti-TB drugs? As I told previously, the most authorities suggest ALT levels more than 5 times or more than 3 times with symptoms. So these are the different guidelines which will define as DILI according to American Thoracic Society. This cutoff levels is ALT more than 200 or ALT more than 120 with symptoms. And the British Thoracic ALT or ST more than 200. There's a 5 times of upper limit and rise in the bilirubin also like more than 2-fold. And the WHO and others are like this is also same as BTS. And next, what drugs to be given after once we stop the first line ATTP? So we can consider the non-hepatotoxic drugs like ethambutol and hepatosafe fluoroquinolone, like levoflox and moxifloxacin, and ofloxacin, ciprofloxacin, and aminoglycoside like streptomycin can be considered in the supportive management for the hepatic dysfunction. In the when to restart the first line anti-TB drugs, like if we once we stop the first line anti-TB drugs, we should introduce, like as per the ATS, if the ALT levels are less than 2 times of the upper limit normal, then we can reintroduce the drugs. As per the WHO and British Thoracic, ALT should be like a within normal limit. But as per our clinical practice, we will follow that whenever the patient ALT levels reaches the baseline, then only we will consider for the reintroduction of the medication. And how to reintroduce? Different guidelines will suggest like in different manners. So there are no single consensus for this like together. And as per the ATS, usually the reintroduction will be like a full dose of rifampicin, then isoniazid full dose within 3 to 7 days if LFT is normal. Then again we will monitor LFT for 3 to 7 days, and then we will start the pyrazinamide. If with the after the introduction of pyrazinamide, if again the transaminitis occurs, then we will defer the pyrazinamide, and then we will choose another drug from the second line drugs. In the as per the British thoracic guidelines, usually isoniazid we will start first. The difference between the American and the British thoracic. So usually the American guidelines, they are starting the full dose, but in the British thoracic they are telling the titration of the dose. So mostly this will be the as in the clinical practice, the dose titration will be a good actually, because usually the drugs which are causing the direct hepatotoxicity, this dose titration will help. So 2 to 3 days, we will start with the 50 mg to 300 mg. We can escalate within 3 days. The daily monitoring of ASTLT. The rifampicin also start with the 75, and we can escalate up to 600 mg. And the same with the pyrazinamide also. Whichever is the offending drug, we have to stop the drug, and we have to go for the alternative second line drug. And the WHO tells that to start all the drugs in the full dosage, monitor LFT, and if delay occurs, usually we will stop. But usually we won't follow this. Sequential introduction of the drugs will be better, so that we will know which is the causing hepatotoxicity.
You will have to close within a minute or two because we cannot overshoot the time.
Okay, sir. So coming to the CLD patient, sir, it's very challenging in the CLD patient, sir. In this in the compensated cirrhosis, especially, it's a prudent to use the 2 hepatotoxic drugs only. The proposed regimens are one is the HRZE for 2 months, followed by the isoniazid and rifampicin for 4 months. There is a 6 months treatment. If you are using alternate regimen, we have to extend the treatment like HRE and fluoroquinolone for 2 months, followed by the isoniazid and rifampicin for 7 months. Here we are avoiding the pyrazinamide. And the if we considering the decompensated liver disease, usually they will require the long duration. So it's like 18 to 24 months of treatment, because we are using the only single hepatotoxic drug. That is the only single first line drug will be there. Most of the times the rifampicin will be preferred. Rifampicin plus ethambutol, fluoroquinolone, injectable aminoglycoside, and cycloserine we can use. And the proposed regimens, with the rifampicin combination, we can use all second line, minimum 3 of the second line drugs for 9 to 12 months. With isoniazid, so we can use all this 3 of the second line drugs. This is also 9 to 12 months. But if we are not using any of the first line drugs, then ethambutol with all second line drugs we can use for that. We had to consider for the 12 to 24 months. So in presence of decompensated cirrhosis with the encephalopathy, so the treatment duration will be 18 to 24 months, along with the non-hepatotoxic drugs with the cycloserine and the capreomycin. And the weekly liver function test should be done initial 2 months, followed by once monthly. as per the child A, 2 hepatotoxic without pyrazinamide or low dose pyrazinamide, duration 6 to 9 months, and the child B only 1 hepatotoxic drugs, that is a 1 first line drug with all 3 second line drugs, duration is 9 to 12 months, and the child C there are no hepatotoxic drugs. We should choose better to choose the all second line drugs with the ethambutol like streptomycin, chloroquine, and duration will be 12 to 24 months. So whenever we are interrupting this first line drugs because of the hepatotoxicity, better to give a reasonable 3 non-hepatotoxic drugs in the meanwhile. And whenever the second episode of hepatotoxicity occurs after the reinstitution of drug therapy, better to stop, and extended duration of anti-tubercular therapy with the second line should be encouraged. Thank you.
I think we have just time for a couple of comments. Dr. Thomas?
Is there any role of N-acetyl cysteine to prevent ATT hepatitis?
Yes, sir.
Toxicity?
Yes, sir. N-acetyl cysteine has a role. As per the new trials, there are no much randomized control trials are there, but some trials are telling N-acetyl cysteine has a role in the supporting the liver. Whenever patient has a along with the stopping of therapy, we can treat with the N-acetyl cysteine.
So it's not prevention; it's once they develop hepatitis.
Yes, sir.
Now, my main concern, my main concern is differentiating adaptation from the DILI is not always so easy. How do you actually differentiate adaptation from DILI?
So actually, if it is like initial days, within starting of like a 3-4 days, if patient have a transaminitis. So if it is,
but we
like
know rifampicin can cause increase. You said it's very early. There may be hepatotoxicity.
Yes, sir. But if it is less than the 5 times of the upper limit of normal without any symptoms, we can continue some days, sir, and we can see and we can repeat the LFT. If it is going more than 5 times, definitely we have to stop, sir. Otherwise, we can wait for another week or another 3 to 4 days, and then we can repeat the test.
So there are occasional cases when tuberculosis is causing hepatitis. Say there is hepatitis where the tuberculosis is involving the liver. Will the approach be different in that situation? When there is liver tuberculosis, we know that sometimes there may be cases of liver tuberculosis. Should you give more drugs or should you give less drugs?
So it all depends on the if there are any cholestasis and with the liver enzymes are more than then actually it is a difficult task whether it is because of the infection itself or due to the hepatotoxicity. But we have to consider the baseline LFT, sir. If before starting the drugs, even the liver enzymes are elevated, then we should take it as a baseline and then we can consider further.
I agree with you, but then we have to be very, very careful in this situation that there may be added hepatotoxicity also. So I think baseline liver function test is very important. Any last comment, Dr. Thomas?
No, sir.
Thank you very much, the whole team, Dr. Thomas and the 2 students for presenting 2 very important topics. Move back to Mr. Singh, please.
Thank you very much, trainees, for the presentation, and thank you very much, Dr. Ronnie Thomas and Dr. Mahesh Goenka for joining us. And thank you, trainees and faculty members, for joining us. Thank you.
Thank you. Bye-bye.
Thank you. Bye. Good night.